Well, thank you for that introduction. It is my privilege on behalf of the Executive Steering Committee, three of whose members are with us today on the podium. I'm going to present the long-term outcomes for BeAT-HF and specifically the Phase 2 portion of that trial that Dr. Abraham's already mentioned. So BeAT-HF was a prospective, multi-center, randomized, two-arm parallel group open label with blinded evaluation trial in which patients were randomized to two groups. First, the BAT plus optimal medical therapy group, and the second is a non-implanted open label control treated just with medical management alone. You can see the number of centers that were studied. You can see the eligibility criteria, important of which are patients were New York Heart Association Class 3 dominantly, with some Class 2 that had been Class 3 in a recent history. LV ejection fraction less than or equal to 35%. You can see the gates for the 6-minute hall walk. They had to have either a hospitalization or an NT-proBNP greater than 400 and be on stable medical therapy. Dr. Abraham's already told you about the pre-market phase of BeAT-HF and the 4 simultaneous endpoints that were looked at, and has told you that on the basis of those data, the FDA gave an approval for the use of this in symptomatic heart failure in 2019. The purposes of the post-market Phase 2 BeAT-HF trial are shown here. First was to test the hypothesis that in patients with heart failure and a reduced ejection fraction, treatment with BAT significantly reduces cardiovascular mortality and heart failure morbidity. And second, to determine whether there is long-term safety and improved patient-centered symptomatic outcomes, which is both durable over time and sustainable in the effect. So the post-market phase is shown to your left here, to your right here. The primary endpoint was cardiovascular mortality and heart failure morbidity, which I'll define further in the next slide, and the pre-specified additional endpoints which are listed here. We used an intention to treat analysis in 323 randomized patients who experienced 332 primary endpoints over a 1,036 patient year follow-up with a median follow-up of 3.6 years per patient. The primary endpoint was cardiovascular mortality, heart failure morbidity, assessed using a negative binomial model, which included recurrent heart failure morbid events. Cardiovascular mortality was cardiovascular death, LVAD or heart transplants. Heart failure morbidity were both hospitalizations and emergency room visits which required intravenous therapy. The pre-specified additional endpoints are shown on the right portion of the slide, and we'll go through all of those in just a couple of minutes. So this is the top-line summary of key evidence. And I'll break this down beginning with the primary endpoint and the components of the primary endpoint, which you can see from this forest plot, did not show a significant difference between BAT and control. On the other hand, both long-term safety and long-term efficacy as measured by quality of life, exercise capacity, and New York Heart Association was in fact durable over time and sustainable in effect, starting with the data that Dr. Abraham showed you out to 24 months. Finally, there are additional analyses that were performed, such as a hierarchical component win ratio analysis and all-cause mortality, each of which favored the BAT group. So let's look at the individual data points in a more detailed fashion. Here, we're graphing cumulative events per patient for the primary endpoint. As you can see, looking at the RR, the rate ratio, there was no statistical difference between the two groups. This was also true in the two components of the primary endpoint. On the left, cumulative cardiovascular mortality, and on the right, cumulative heart failure morbidity. Again, no statistically significant difference between the two groups. Now let's turn toward the long-term durability of safety and the efficacy endpoints of symptomatic relief. This device, remember, was extravascular and had a very durable, safe profile in terms of MANTS as major adverse neurologic and cardiovascular system or procedure-related event rate, with a 97% MANTS-free rate, which was maintained through the entire course of the trial. Let's begin next with the symptomatic endpoints. This is quality of life using the Minnesota Living with Heart Failure questionnaire. We looked at the change from baseline to 6 months, 12 months, and 24 months. The BAT group are plotted in red, control group in blue, and the difference between the two in green. So pay most attention to the green bar. You can see that at each time point, there was a large and significant improvement in quality of life, each of which very much exceeded the meaningful cutoff level of 5 points. So at each point in time, there was almost a doubling of that threshold. The same thing is true for exercise capacity as measured by 6-minute hall walk distance. Here we have data from 6 and 12 months. And you can see that the hall walk distance increased in the BAT group by more than 50 meters, which is twice as much as what we all accept as a clinically meaningful endpoint. And then this looks at the New York Heart Association functional class, graphing the percent of patients who had at least a 1-class improvement over time. And at each point in time, if you look at the green bars, this was more prominent in the BAT group versus the control. So in all 3 of these symptomatic endpoints, the endpoint improvement in BAT was durable over the time of the trial and sustainable in the effect at each point. On each of the last 3 graphs, there's no difference in the improvement level between time periods. They were all statistically significant. Okay, in order to get a more holistic look at the totality of the data, we performed a pre-specified hierarchical composite using a win ratio analysis. And the rationale for doing that is stated on this slide. If you look only at cardiovascular mortality and morbidity, only about 40% of the patients actually contribute to the endpoint. Whereas if you use a win ratio, virtually 100% of the patients contribute to the endpoint. We had a 5-level hierarchical comparison. I've combined 2 of them so that there are only 3 here for ease of presentation. The first was cardiovascular mortality, which is death, LVAD, and transplant. The second is heart failure morbidity, including both hospitalization and ED visits. And then the third is quality of life. So the ratio of total wins in the BAT group versus the control is the endpoint that's being measured with the Finkelstein-Schoenfeld statistical analysis. And that's shown here. On the far left, you can see the 3 groups, mortality, morbidity, and quality of life. The orange-colored squares show the number of wins in the BAT group versus the control data in blue, which shows the number of wins in the control group. And if you look to the bottom of the slide, you can see that the actual win ratio itself was 1.26, meaning that there were 26% more wins in the BAT group than in the control. And this reached the nominal p-value of 0.04. Importantly, if you look at the contribution of each of those categories to the improvement in win ratio, in green on the far right, you can see that each of those categories contributed about equally. So this is not weighted just towards a single endpoint, but balanced between all 3. Okay, last data point before my conclusion is that if you look at the freedom from all-cause death, LVAD and transplant, BAT resulted in a 34% reduction in the relative risk ratio, which reached the nominal p-value that was near significant of 0.054. So while the primary endpoint and their components did not reach a statistical endpoint and were neutral, we would like to conclude that the totality of the evidence indicates that BAT is safe, effective, and durable for the treatment of patients with heart failure and a reduced ejection fraction. Now, if you'll bear with me for a minute, I want to return to this summary of key evidence slide and highlight the two components of the primary endpoint. First, there are no statistical differences between any of the three endpoints that are outlined in purple. However, you can see that there is a trend towards a reduction in mortality favoring BAT, but a trend in morbidity which favors control. Again, no statistical difference between those, but all of you in the audience and all of the people that have ever talked to me about this have asked the question, why is the heart failure morbidity on the wrong side of the line of unity? And we've spent the last 6 months trying to understand what might be responsible for that. And there's some very interesting data. One of the potential confounders in this is the effect of COVID. Here we're showing where the patient's journeys were in relationship to the calendar year on the bottom, and we selected the year 2020 as the most important COVID pandemic period. Remember, this is when the pandemic was raging. We had no treatments for it. We had no immunizations for it. It was during that period of time where the highest impact of COVID was in this trial and other trials that have looked at it. So if you look at this morbidity, heart rate morbidity rate chart, it's now per calendar date. So on the horizontal axis is per calendar, and you can see a remarkable finding that during the year 2020, in the control group only, the rate fell to near zero. This did not happen to cardiovascular mortality. There was no difference between control and BAT during 2020 for cardiovascular mortality. If you look at the absolute values, you can see that the one value that's clearly standing out as different is the control group during 2020 that almost had a zero event rate. That was statistically significant from an interaction p-value analysis, which I think gives us the gravitas to and the justification to move forward in these kinds of analyses to try to understand what was COVID doing during that period of time and how did our patients react to it. So the first conclusion here is that COVID altered the heart failure morbidity rate in the control group in a selective and disproportionate manner. We would have liked to show you data on site-reported heart failure morbidity, but we don't have that data available. As a surrogate for that, we looked at site-reported cardiovascular serious adverse events. And what you can see in the control group is that there is some change during the COVID period. But this is a complicated slide, so I'm going to take just a couple of seconds longer to go through it. Let's look first at the data highlighted in red. So this is the control group to the far right, not during 2020, meaning all the other times, versus 2020. And pay attention to the two circled values. What you can see is that serious adverse events were reduced by almost 44% in the control group only during 2020. In addition, if you look at how many of those serious adverse events were subsequently adjudicated by the Clinical Events Committee as a primary endpoint, you can see that ratio falls from 52% to 22%. These data were not the same as in the BAT, which had no difference across time in the serious adverse event rates, nor did it have a change in the conversion from serious adverse events to CEC adjudicated primary events. So what do we do about this? We've asked as many people as we can find, how do we make an adjustment for this anomaly? And we've worked with NAMSA, Harvard, London, and the FDA to come up with the following schema. We did both restricted and expanded analyses. By restricted, we meant we just simply excluded the heart failure morbid events in both groups during 2020. Expanded meaning instead of using heart failure morbid events, we used cardiovascular SAEs as reported by the site. And then the third is a repeat of the same, but excluding the 2020 data. When you do that, you can see that the point estimates highlighted in yellow here all fall below 1. So that if you look back at this forest plot and look at where we started in the circled blue, now look at the circled red, all of these adjusted analyses fell to the right of the line of unity, allowing us to say that COVID altered the morbidity rate in the control group in a selective and disproportionate manner. That when that COVID effect was blunted or removed, the point estimates became concordant and fell on the same line of unity. And the data suggests that really, if you factor in COVID, there's no discordance between those two components of the primary endpoint. So while the primary endpoint was not met and was neutral, we still believe that the totality of the evidence, even more supported by the COVID data, indicates that BAT is safe and effective, durable for patients with heart failure and a reduced ejection fraction. And thank you for your attention.